Good morning, everyone. Today we are going to learn about the caecum and appendix. So in this class, we are going to discuss about the caecum and appendix. It's included in the large intestine. So first we'll see about the features of the large intestine, its cardinal features. Then we are going to discuss about the caecum and appendix. Okay. Then we are going to discuss about the applied aspects. What are the clinical conditions we have to learn in this caecum and appendix? That's we are going to learn today. So first we'll see the features of large intestine. So earlier we discussed about the small intestine. No? So you know duodenum, jejunum and ileum that continues as the large intestine. When you see the large intestine, it will be around 1.5 meter long. From where to where it extends. Just see here. So here you are seeing the large intestine. It extends from the caecum to anal canal. Okay. So here you are seeing the caecum and this is the anus. So this part it is called as large intestine. This is fixed in position. When you see the large intestine, they are fixed. Okay, they are retroperitoneal. When you see the ascending colon and descending colon, they are retroperitoneal structures. Okay, when you see here, so in this picture, you can see in the right side, this is the ileum. This ileum opens into the caecum. This caecum continues as ascending colon, transverse colon, descending colon. Then you can see the sigmoid colon. Sigmoid colon, it continues as rectum and it ends in the anal canal. So large intestine, it includes caecum. Here you can see a small tube-like structure, that is the appendix. Here, this ascending colon, transverse colon, descending colon, they collectively called as colon. Okay, you can see the colon. Then here is the rectum and anal canal. So in this class, we are going to discuss in detail about the caecum and appendix. So in this picture also, you can see the large intestine. Okay. Now, what are the features of the large intestine? What are the cardinal features of the large intestine? Large intestine, it consists of three cardinal features. They are tinea coli, saculations, appendices epiploicae. So here you are seeing the tinea coli. It's a thick ribbon-like band. Okay, it's a band-like structure. You can see over the large intestine. Saculations, it's also called as hostrations. If they are on either side, you can see the large intestine, it has sacules, dilatations. Okay, it's also called as hostrations. Appendices epiploicae, they are fat-filled peritoneal pouches. So here in this picture, you can see this appendices epiploicae. It's nothing but within the peritoneal fold, there will be accumulation of fat. So a fat-filled peritoneal pouches, they will be attached to the large intestine. So these are the three cardinal features of large intestine. When you see these three cardinal features, you can identify it as a large intestine. Okay, so tinea coli, it's a band. Okay, it's a band. We have three types of tinea coli. Okay, when you see the large intestine, it has the surfaces, anterior surface, medial, posterior surface will be there. Within that surface, you can see these three bands. So anteriorly, you can see this tinea libra. Then posteriorly, you can see the tinea omentalis, and medially, you can see the tinea mesocolica. So these are the three bands seen over the large intestine. All these three bands, they end in the caecum. In that particular part, you can see the appendix. So here you can see saculations or hostrations and appendices epiploicae. So these are the three cardinal features of the large intestine. So in this picture, you can clearly see the tinea. Here you can see the appendices epiploicae. Okay. So, and you can see the ostrations, saculations on either side. Okay. So this tinea coli is nothing but the thickening of the longitudinal muscle fibers. You can see anteriorly you can see a thickening, medially you can see a thickening, and posteriorly also you can see the thickening. Okay, so they are the tinea. Now we are going to see about the cecum. Okay, so in this part you can see this dilated sac-like structure that is named as cecum. It's seen the right side. Okay, this dilated sac-like structure that is called as cecum. So this is when you see the height or length and breadth, they will be more compared to the rest of the part of the large intestine. So this is the location of the cecum. So here you can see this is the ileum. Ileum opens into the cecum. So what is the location of the cecum? This cecum, it is located in the, here you can see the iliac fossa. Now you know the quadrants of the abdomen. So here you can see this part, this is the epigastric region. This is hypochondriac, right hypochondriac, left hypochondriac. This is umbilical region. This is right lumbar, left lumbar. Here you can see this is right iliac, left iliac. Okay, so this is the right iliac. Okay, here you can see it's marked as cecum. No? So this is the location of the cecum. So where it's exactly located means in the right iliac fossa, you can see two lines. Okay, so you can see the two lines. This is named as right lateral plane. This is called as transtubercular plane. So right lateral plane and transtubercular plane. So in between the right lateral plane and transtubercular plane, you can see the right iliac fossa. Within that, you can see this dilated sac-like structure that is called as cecum. Okay, so this is the location of the cecum. Now, what is the size of the cecum? The length of the cecum will be around 6 centimeter. The breadth will be around 7.5 centimeter. So the breadth will be more compared to the length of the cecum. See, in this picture, the breadth is more. It's around 7.5 centimeter. Okay. So shape, it is here asymmetrical, dilated, pendulous, sac-like structure. So asymmetrical. Okay. So on the right side only we have the cecum. So it is asymmetrical and it is the most dilated part of the large intestine. So it is a asymmetrical, dilated, pendulous, sac-like structure. So in this sac-like structure, you can see two openings. So one is for the ileum, another one is for the appendix. Okay. Now, types of the cecum. So after birth, there will be growth of the cecum. So when you see, we have 4 types of the cecum. The first type, it is also called as fetal type or conical type. In the fetal type or conical type, it will be have a pointed end below. From that part, you can see the origin of the appendix. So that is named as fetal type or conical type. The next type, it is also called as infantile type or type 2 cecum. So it is also called as quadrate type. You can see it is quadrate in shape. Okay, it is quadrate in shape. You can see 2 sacules on either side. Right cecal sacule and left cecal sacule. The next type is the normal type. So this is the normal one. It is seen. So in this, that's right sacule, it will be enlarged more compared to the left sacule. So this is the normal type. So in between the right sacule and small left sacule, you can see the position of the appendix. Base of the appendix will be seen. The fourth type is exaggerated type. In exaggerated type, the right sacule will be enlarged more compared to the left sacule. So that is named as exaggerated type. So 4 types of cecum is there. So fetal type, infantile type, the next one is normal one, that is the type 3, and the fourth one is exaggerated type, that is the type 4. Okay, is it clear? Now we'll see the relations of the cecum. So it is located in the right iliac fossa. So what are the structures related anteriorly and what are the structures related posteriorly that we have to know. So anteriorly, so already in the section you are seeing the structures, no? So when we remove the skin, superficial fascia, deep fascia of the abdomen, you can enter into the then you can see the muscles. After reflecting the muscles, you will be entering into the peritoneum. So in the right side, after removing the anterior abdominal wall, you can see the greater omentum. It fully covers the anterior abdominal wall. So that not anterior abdominal, under that anterior abdominal wall, you can see the greater omentum. So it covers the organs. Okay, it's also called as policeman of abdomen. No? So the greater omentum will be seen. Not in all cases. Sometimes it won't cover. Okay, only half of the abdominal organs they will be covered by omentum. Below there won't be omentum. It varies. Okay, but in common, below the anterior abdominal wall there will be a greater omentum. When you reflect the greater omentum, you can see the coils of small intestine. So small intestine they will be arranged in lobes, coils. So they will be seen all over the abdominal cavity. So when you take the coils of small intestine, you can see the cecum. So anteriorly, what are the structures arranged? First, anterior abdominal wall, then greater omentum, then coils of small intestine will be there. So these are the relations anteriorly. Now, coming to the posterior relations. What are the structures seen posteriorly? So when we take the cecum out, so here in this picture, this dotted line, it indicates the position of the cecum. When you reflect that cecum, under that you can see the posterior abdominal wall. So this is in the right iliac fossa. No? So in the right iliac fossa, the structures present in the posterior abdominal wall will form the relations posteriorly. So you know already we have psoas major medially, then laterally quadratus lumborum will be that, but this cecum it lies in the iliac fossa. So in the iliac fossa, what muscle you know? We have the iliacus muscle. So that iliacus muscle, it is related posteriorly. So posteriorly, we have psoas major muscle, iliacus muscle. Then in this picture, you can see this is the abdominal aorta. This divides into common ilia. Then you can see the external iliac artery. So this is the external iliac artery. So this external iliac artery will be seen posteriorly. Then you can see one more vessel, that is the right gonadal vessel, because see in right side only cecum is there. So only right gonadal vessel, it forms the boundary posteriorly, relation posteriorly. So this right gonadal vessel, it arises from which vessel? It's from abdominal aorta. So here you can see right gonadal vessels, external iliac artery, it is related posteriorly. Then you can see a nerve. This is the genitofemoral nerve. Genitofemoral nerve. Here also you can see one more nerve, that is the lateral cutaneous nerve of thigh. Then you can see the femoral nerve. So these are the structures related posteriorly. So posteriorly, cecum is related to external iliac artery, right gonadal vessels, lateral cutaneous nerve of thigh, femoral nerve, genitofemoral nerve. Then two muscles related posteriorly, they are psoas major and iliacus. So these are the relations posteriorly. Now, cecum, it is covered by peritoneum. So we can able to see folds of peritoneum. Because of that fold, under that we will be having the spaces. So those spaces, they are called as recesses. So near the cecum, we have three peritoneal folds. They are superior ileocecal fold, inferior ileocecal fold, and posterior cecal fold. Under these three folds, there will be spaces. They are called as recesses. So in this picture, you can see the superior ileocecal fold. This superior ileocecal fold is seen above the ileum. It connects the cecum with the posterior abdominal wall. So that is the superior ileocecal fold. Under the superior ileocecal fold, there is a space that is called the superior ileocecal recess. Okay, so this is the superior ileocecal fold and superior ileocecal recess. The next one, inferior ileocecal fold. Here you can see a fold below the ileum, below the terminal part of ileum. It's connecting the ileum and appendix. So this is called as inferior ileocecal fold. Inferior ileocecal fold. Under that fold, there is a space. That space is called as inferior ileocecal recess. Inferior ileocecal recess. Okay. The next fold is posterior cecal fold. Posterior cecal fold. So here, this is the cecum. We are viewing this from posteriorly. You can see a fold, that is the posterior cecal fold. So three folds are there: superior, inferior, and posterior cecal fold. Here, you can see in the superior ileocecal fold, there is a blood vessel. Okay, you can see the blood vessels, no? So because of the blood vessel, this fold, it is also called as vascular fold of cecum. Vascular fold of cecum. When you see the inferior ileocecal fold, there is no blood vessel. So this fold, it is also called as bloodless fold of Treves. Bloodless fold of Treves. So during surgery, if you approach through this fold, means the loss of blood loss will be very less. Okay, so usually it will be approached through that. So this is called as bloodless fold of Treves. Okay, so this is about the peritoneal folds and recesses. Okay, is it clear up to this? Okay, are you following now? So up to this, what we have seen, first we have seen about the cardinal features of large intestine. Then we start with the cecum. We have seen about the location of the cecum, where it is located, in which quadrants it is located. Then what are the features of the cecum we have seen. Then we discussed about the relations anteriorly and posteriorly. Now we also seen about the peritoneal folds and the recesses. The next one. So after seeing all this, you are going to see the interior of the cecum. What is seen inside the cecum? So when you see the cecum, when you cut open the cecum, inside that you can see two openings. Two openings. They are also called as orifice. You can see two orifice. So one is ileocecal orifice, another one is appendicular orifice. Here you can see this upper one, that is the ileocecal orifice. It's nothing but the ileum opens into the cecum. So that is named as ileocecal orifice. So the contents of the ileum, they enter into the cecum through this orifice. We have some special feature in this ileocecal orifice. When you see this ileocecal orifice, it is transversely placed. It is transversely placed. The upper one, that so it is opening, no? So there will be formation of a fold. So that upper fold, it's also called as upper horizontal lip. The lower fold, it's also called as lower concave lip. So the upper fold will be horizontally placed and the lower fold will be concave. Okay, so when you see this upper and lower fold, they join laterally. That extension, it is called as frenulum. Frenulum. So when you see the ileocecal orifice, it is transversely seen. It connects the ileum with the cecum. The upper fold will be transversely placed and the lower fold will be, they are concave. And two folds, they join laterally. That is named as frenulum. Okay. So this is about the ileocecal orifice. The next opening, a small round opening you can see, that is called as appendicular orifice. Appendicular orifice. So here the appendix, it communicates with the cecum through this appendicular orifice. It is round or circle. This appendicular orifice, it is also called as valve of Gerlach. Valve of Gerlach. Okay. So this is the appendicular orifice or valve of Gerlach. So these are the features we can see inside the cecum. Okay, so inside the cecum you can see two orifices, one is ileocecal orifice, another one is appendicular orifice. Now the next one what we are going to learn is blood supply of the cecum. So before that, just we'll refresh about the blood vessels. Okay, so we already discussed about the celiac trunk. Here you can see superior mesenteric artery and inferior mesenteric artery. Just we'll see about the branches. In this picture, you can see the superior mesenteric artery. It gives rise to middle colic artery, right colic artery, ileocolic artery. Okay. This inferior mesenteric artery, it gives rise to left colic. Here you can see sigmoidal branches. Now we are discussing the cecum. No? So what we need is this ileocolic artery. See here the ileocolic artery. It's a branch of superior mesenteric artery. Okay. Now we'll see about the veins. Okay, venous drainage of this intestine. Here you can see this is the superior mesenteric vein. Here you are seeing the superior mesenteric vein. This is the splenic vein. They form the portal vein. So when you see tributaries of superior mesenteric vein are ileocecal vein, ileocolic vein, right colic vein, middle colic vein, and you can see jejunal and ileal veins. So this ileocolic vein we have to concentrate. So this ileocolic vein, it drains into the superior mesenteric vein. Okay, so this ileocolic vein that will be draining the cecum. Now blood supply. We'll see. So blood supply. Now you know the arteries and veins in the abdominal cavity. Now we'll discuss the blood supply of the cecum. The cecum, it is supplied by two arteries. They are anterior cecal artery and posterior cecal artery. Anterior cecal artery. Here in this picture you can see this is the anterior cecal artery and this is the posterior cecal artery. So these two arteries, just see here, this is the branch of ileocolic artery. So now you know what is ileocolic artery. It is a branch of superior mesenteric artery. So that ileocolic, it divides into anterior cecal artery and posterior cecal artery. This anterior cecal artery, when you trace here, it supplies the ascending colon and also the cecum. When you see the posterior cecal artery, it passes behind the ileum and it supply the cecum and also the appendix. In this picture itself, it's clearly given. Okay, so cecum, it is supplied by anterior cecal artery and posterior cecal artery. Now we'll see about the venous drainage. Here in this picture you can see this is the cecum. So we already know about the ileocolic vein. So the cecum, it drains into ileocolic vein. Finally it reaches the superior mesenteric vein. Superior mesenteric vein joins with the splenic vein, that forms the portal vein. Okay, so the ileocolic vein that drains the cecum. Okay. So up to this, is it clear for you? So we discussed the blood supply, venous drainage. What is the next one? What we are going to discuss? That is the nerve supply. Okay. So you know all the organs, they are under control of autonomic nervous system. So you know autonomic nervous system, it consists of sympathetic fibers, parasympathetic fibers. So here also the cecum under control of autonomic nervous system. So here we have sympathetic fibers and parasympathetic fibers. Now you can see the sympathetic fibers, they formed by T10 to L1 segments. Okay, so they arise from T10 to L1 spinal segments. Okay, they form the superior mesenteric plexus and it supplies the cecum. Parasympathetic fibers, as you know, vagus nerve. So most of the organs in the abdominal cavity, they are innervated by the vagus nerve. Okay, so parasympathetic fibers, they arise from the vagus nerve. Okay, so nerve supply, it's by the autonomic nervous system. We have sympathetic fibers, parasympathetic fibers, sympathetic fibers, T10 to L1 segments, parasympathetic fibers, vagus nerve. Okay, so this is the nerve supply for the cecum. The next one is the lymphatic drainage. Okay, so when you see, we have the group of lymph nodes near the ileum and cecum. We have ileocolic lymph nodes near the cecum and colon. Okay, so they are arranged in two groups, upper group and lower group. So these ileocolic lymph nodes, they drain the cecum. Okay, so ileocolic lymph nodes, upper group and lower group, they drain the cecum. Okay, so this is about the lymphatic drainage of the cecum. Okay, so after this, is it clear? No, what we discussed? We discussed the location of the cecum, then we discussed the relations, then we discussed the external features, internal features, blood supply, nerve supply, lymphatic drainage. Okay, so the last one is the applied aspects of the cecum. Okay, so what we can discuss in the cecum? What happens? So one condition that is called as intersusception. Intersusception means one part of the colon that invaginate into another part of the colon. So this is also called as tube within the tube. Just it will go inside. Okay, so that is called as intersusception. This may happen, sir. So in the cecum also it may happen, sir. A part of the colon may enter into the next part of the colon. Okay, that is called as intersusception. Okay. So when there is obstruction in the when you see, so in some cases they will be coming with the intestinal obstruction. Okay, when you do some investigations, when you take the ultrasound or CT MRI, if you see the cecum is dilated, it is loaded, means obstruction will be in the large intestine. Okay, so obstruction will be in the large intestine. If it is empty, means obstruction in the small intestine. By seeing this, you can identify whether it is small intestinal obstruction or large intestinal obstructions. Okay, so this is about the cecum. The next one, what we are going to discuss is the appendix. So it's also clinically very important topic for you, appendix. Okay, so appendix, as you know, it is a tube-like structure. You can see in this picture, it is a tube-like structure. So it is a tubular diverticulum. It arises from the posteromedial wall of the cecum. Here is the cecum. In the posteromedial wall, you can see the appendix. So it is a tubular diverticulum arises from the posteromedial wall of the cecum, 2 centimeter below the ileocecal junction. Here, this is the ileum. This is the cecum. Okay, this is the ileocecal junction. 2 centimeter below that, you can see the attachment of the appendix. So appendix, it is a tubular diverticulum. It's arises from the posteromedial wall of the cecum, 2 centimeter below the ileocecal junction. Okay. So what is the measurements? It measures around 2 to 20 centimeter. So it may be 2 centimeter, 5 centimeter, up to 20 centimeter length of appendix we can see. So it varies 2 to 20 centimeter. The width will be around 5 millimeter. Okay. Now, what is the location of the appendix? So in this one, you already know quadrants of the abdomen. You know this is the right lateral pin and this is the transtubercular pin. So in between the intersection, you can see the right iliac fossa. In that right iliac fossa, what is located? You know that, no? That is the cecum. Okay, so this one is the location of the cecum. 2 centimeter below the intersection, we have the position of the appendix. Here you can see transtubercular plane, right lateral plane. 2 centimeter below that, you can see the position of the appendix. So this is the surface landmark for the appendix. Okay. Now we have to know one most important point, that is the McBurney's point. McBurney's point, you can see this is the umbilicus. This is the anterior superior iliac spine. When you connect these 2 points by a line, that is named as spino-umbilical line. Spino-umbilical line. At the junction of medial 2/3 and lateral 1/3, when you put a point, that point is called as McBurney's point. What is the importance of the McBurney's point? So this is the most important landmark. So when you compress this point, the patient with appendicitis may feel pain, tenderness. Okay, so tenderness in the McBurney's point, this indicates the inflamed appendix. So it is surgically, it's very important, McBurney's point. Okay. So in this picture, you can clearly see this McBurney's point and the presence of base of appendix 2 centimeter below that right lateral plane and the transtubercular plane. Any doubt up to this? Yeah, shall we continue this one? Yes. Now we'll see about the parts of the appendix. So in this picture, you can see this appendix. It's seen in the posteromedial wall, 2 centimeter below the ileum. It consists of base. This is the base. Here is the body and tip. So 3 parts. This is the base. This is the body of the appendix, and this is the tip of the appendix. And the appendix, it is connected to the ileum by a fold of peritoneum that is named as mesoappendix. Mesoappendix. So the appendix, it consists of base, body, tip. Appendix, it is connected by a fold of peritoneum that is named as mesoappendix. Now, various types of appendix are there. The types means it depends upon the position of the tip of the appendix. So this is the base. No, base will be constant. But when you see the tip, it may vary. It may go behind the ileum or in front of the ileum, or it goes towards the inguinal fold, or it goes behind the caecum like that. So depends upon the position of the tip, we divide this into various types. So this many types are there. They are subcaecal or paracolic. Subcaecal or paracolic. This is 11 o'clock position. Retrocaecal or retrocolic, 12 o'clock position. Splenic type, promontoric type, pelvic type, midinguinal type, ectopic type. So these are the types of appendix. We'll discuss with a picture. Here you can see this is the tinea. When you trace the tinea, you can find the base of the appendix. Now we can see the types. First one, see in this picture, 11 o'clock, paracolic. Okay, here you can see paracolic on the side of the ascending colon, 11 o'clock position. Okay, paracolic type. The next type is retrocaecal or retrocolic, behind the caecum. Okay, the appendix tip will be pointing to behind. It passes behind the ascending colon and it is towards the liver like that. So it is retrocaecal, 12 o'clock position. The next position is splenic type. It is towards the spleen, So in the left side spleen will be there, no? So it will be towards the spleen. If it is in front of the ileum, means that is called as pre-ileal type. When it is behind the ileum, that is called as post-ileal type. Okay, 2 types are there, pre-ileal, post-ileal. When it is in front, that is named as pre-ileal. When it is behind, that is named as post-ileal type. That is splenic type. The next one, promontoric type. Promontoric, why we named it as promontoric? It is going towards the promontory of the sacrum. Okay, promontory of the sacrum. So that is named as promontoric type. This is the promontoric type. The next type is pelvic type. So this one, okay, this is going towards the pelvis. No? So this is named as pelvic type. The next one is this is subcaecal or midinguinal type, 6 o'clock position. 6 o'clock position, midinguinal type. So these are the types of the appendix. So base is constant, only the position of the tip will vary. Okay, so depends upon that we have various types. They are the paracolic, the retrocaecal or retrocolic, splenic type. Within that we have pre-ileal, post-ileal type, promontoric type, pelvic type, midinguinal type. Within that, most commonest type is the retrocaecal or retrocolic type. The next commonest is the pelvic type. Okay, so the second commonest is the pelvic type. Okay, so up to this, is it clear? Sure, shall we continue now? So, okay, the next is the ectopic type. Ectopic type means sometimes, you know, midgut rotation is already over, no? So when there is error in the rotation of the midgut, the position of the appendix may vary. Okay, in case of subhepatic type of appendix, it will be seen near the liver. Sometimes it will be seen near the umbilicus. Sometimes it will be seen near the left iliac region. So it varies, the position varies. That appendix, it is named as ectopic type of appendix. Ectopic type of appendix. So it is due to error of rotation of the midgut. Okay. So these are the various types of appendix. Now coming to the blood supply, arterial supply of the appendix. So it is supplied by appendicular artery. Appendicular artery is nothing but the branch of ileocholic artery. You already know what is ileocholic artery. Here you can see this is the ileocholic artery. It gives rise to anterior cecal artery, posterior cecal artery, and here you can see this posterior cecal artery, it gives rise to the appendicular artery. So this appendicular artery is a branch of ileocholic artery. Okay, so this artery passes behind the ileum and it supplies the appendix and it supplies the appendix here. Okay, so this is the arterial supply of the kidney. So it is supplied by arterial supply of the appendix. Okay, so it is supplied by appendicular artery. It's a branch of ileocholic artery. Okay, the next one is venous drainage. So where it drains? So here you can see ileocholic vein. See here, this appendicular vein, it drains into ileocholic vein. Finally, it enters into the superior mesenteric vein. Okay, so superior mesenteric vein, that is the venous drainage for the appendix. Okay, the next one is lymphatic drainage. Lymphatic drainage. So where it drains? So it's drained by ileocholic nodes. Ileocholic nodes. Here you can see we already discussed. No, we have upper ileocholic nodes and lower ileocholic nodes. This ileocholic nodes, it drains into superior mesenteric nodes. So it drains into this, finally drains into the superior mesenteric nodes. Okay. So this is about the lymphatic drainage. What is the nerve supply? We already discussed. It's supplied by autonomic nervous system. Okay, the autonomic nervous system. We have sympathetic fibers, parasympathetic fibers. Sympathetic fibers, it arises from T10 segment. Parasympathetic fibers, they are by the vagus nerve. So sympathetic fibers, they arise from T10 segment of spinal cord. So they form the superior mesenteric plexus and it supplies. Parasympathetic, as you know, it arises from the vagus nerve. So all organs, abdominal organs in our body, they are under control of autonomic nerves. Particularly if it is parasympathetic, they arise from vagus. Sympathetic means a particular segment. From a particular segment, they will supply the organs. Okay, so this is about the nerve supply of the kidney. Now coming to the microstructure of the kidney. Okay, so sorry, microstructure of the appendix. When you see, you know the layers of the GIT, you know. So we have mucosa, submucosa, muscularis externa, serosa. Here you can see mucosa, submucosa, muscularis externa, and serosa. So in the mucosa and submucosa, you can see aggregation of lymph nodes. Lymphatic aggregations will be there. Okay, lymphocytes, everything, they will be aggregated. So lymph nodules will be there. By seeing the lymph nodules, you can identify the appendix. Okay, so these are the 4 layers of the appendix. Now coming to the development of the appendix. Okay, where it develops. Okay, so we already discussed the midgut embryology. It's over. Just we'll refresh where it develops. Okay, so when you see, this is the midgut. This is the midgut. We can see this is the cranial part of the midgut and this is the caudal part of the midgut. From here you can see the attachment of the yolk sac. So when you see from the caudal part, a diverticulum is extending. That diverticulum, it is named as cecal diverticulum. That diverticulum is called as cecal diverticulum. From the cecal diverticulum, a conical extension will be arising. That part is called as appendix. So this appendix and cecum, they arise from caudal limb of the midgut loop. Caudal limb of the midgut loop. Later on, this appendix, they will grow and they will either it may pass through retrocecal or pelvic, that depends. Okay, so and simultaneously what happens, cecum also will be developing. No, we discussed various types of cecum. No, so fetal type, infantile type, like that. So the circulations will be arising. No, so after circulations arise, this appendix position will be constant. Okay, so what is the development of cecum and appendix? It develops from caudal limb of the midgut loop. Caudal limb of the midgut loop. Okay. So is it clear? No development. Now we'll see about the applied aspects in the midgut. What are the clinical conditions, sorry, applied aspects in the appendix? What are the clinical conditions we can see in the appendix? Most common one is the appendicitis. Appendicitis. You can see so many patients, they will come with the appendicitis. So it's the most common one. It is due to inflammation of the appendix. Inflammation of the appendix. Main causes mostly the appendicular, it's a tube-like structure. No? So the fecal may obstruct it. Further, there will be infection, inflammation that will lead on to appendicitis. The patient will comes with the complaints of pain in the iliac fossa. At first, it will be seen around the umbilicus because T10 dermatome that supplies the umbilicus, and also the same T10 it supplies the appendix. No, so there will be referred pain. So first, the pain will be seen in the umbilicus. Later on, due to local peritonitis. Due to local peritonitis, because infection, inflammation, it will burst in the iliac fossa, it enters the peritoneal cavity. Due to that localized peritonitis, the pain will be transmitted to the right iliac fossa. So first, patient first comes with the complaints of the first pain, it appears in the umbilicus. Later on, it will be referred to the right iliac fossa. Okay, so pain will be the first one. And you can have to ask the course of the pain, where it exactly starts and now where is the pain. Now a patient comes with the complaints of vomiting. So vomiting will be there, fever will be there. So when you see these symptoms, you can come to a diagnosis of appendicitis. You can do the ultrasound also. Okay, by all these symptoms and the features in the ultrasound, you can come to a conclusion of appendicitis. So treatment is appendicectomy. So removal of the appendix is the treatment for the appendix. Okay. So apart from that, what are the things we can see means gangrene of the inflamed appendix. If the appendix it is inflamed means it will result on the gangrene. And sometimes inconsistency of position during surgery of appendicectomy, it is very difficult to sometimes it will be difficult to identify the position, because you know various types are there. It may go above, behind the cecum, or it may be towards the spleen, pre-ilial or post-ilial. So identifying the position, exact location of the appendix is the crucial part in the appendicectomy. Otherwise, it's the easiest surgery, but the thing is identifying the position. Sometimes if it goes retrocecal means it will be very difficult to identify. So how we can identify the base of the appendix? All the tinea will meet in the base of the appendix. So trace the tinea, you will end into the base of the appendix. So position is very important. Subhepatic position is the most difficult part to identify, and appendicitis mostly it's uncommon in infants and elderly people. Okay, so in infant and elderly, the appendicitis is very rare. Okay, so in middle age adults, they will be affected more. Okay, so this is about the appendix. Okay, so is it clear today what we discussed? We discussed the features of large intestine. We discussed about the cecum and appendix. Okay, so is it clear? So appendicitis is the most common clinical case you can see. So any doubts you have? Any doubts? Let me know. So read this part. Okay, so clinically this is very, very important. Okay. So we conclude the class. Thank you so much. Okay. Yeah. Thank you.